Okay, good afternoon to all of you. Welcome again to this recorded session. As per my previous webinar, again, my apologies for not doing this as an interactive session. We've had a little bit of an issue with the internet here. Pardon me. But I hope that this will be sufficient for the time being. If there are any other questions on this, then feel free to contact me at the office at Pharmacists. My name is Dippin, and I'm the Head of Services, Professional Services of Pharmacists. Today, this is going to be the Pharmacist session, and we're going to be talking about epilepsy today. Now, slightly different slant on most presentations. This is going to be based more upon a slightly more clinical form of presentation. We're going to be looking at epilepsy really from the eyes of a GP, what they do, what they see, what they should do if they just think there's somebody with epilepsy, and we're going to be talking about things like the quality of outcomes framework, how you manage epilepsy, and a few other things as well. So it shouldn't take too long. I should hopefully be finished off in the next 10-15 minutes or so. So first of all, those of you who are not familiar with this, we tend to do these in mind maps. It's a lot easier to sort of like discuss a lot of information in one go. If you want this mind map, then please let me know at the office and we will send it over to you by email. So, pardon me, in typical surgery, around about 2,000 list patients, whatever, there are around about 8 patients or so with epilepsy. So we're looking at around about, a little bit less than around about 0.5% of a population. So in general, that's what we would tend to expect. Now, if somebody comes in with a seizure of some sort, what we need to do is the GP would generally tend to suspect epilepsy after a seizure, for example, uncontrolled nervous activity, or with or without a convulsion or loss of consciousness. What they would then do, they would take a careful history from the patient. If they can, they would try and get witnesses to see what happened as well. And particularly references should be made to things like rigidity, shaking, loss of consciousness, and a few other things here, tongue biting, etc. There are different types of epilepsy around, so things like focal seizures and absence attacks should also be included. And all patients that are suspected of having epilepsy should be referred not to the GP but to a specialist neurologist, even after a single seizure. Pardon me. There are things that you can get mixed up on, and there are differential diagnoses. In other words, there are other things that could cause seizures as such. An example of things like syncope, and there are some sort of like symptoms associated with that here. There's transient ischemic attacks, TIA, and you get some similar sorts of things with that one. And there's also other things as well. So if I move this on a bit, you got things like other psychogenic things, panic attacks, migraines, etc. So you can get other things that are similar to in their appearance to epilepsy, but these are the sort of things that you may want to consider as well as a GP, just in case. Now let's talk about the management. Okay, we're going to be talking about two parts of the management. If it's initial management and what you would do during a fit as well. In the form of initial management, in other words, that's when you get a patient that you suspect may have epilepsy. What do you do in the first instance? It's quite simple. The GP would refer them. All right, they would refer them on to a neurologist with an interest in epilepsy, and if possible, they'll be accompanied by witnesses to the attacks as well. There is a slightly different thing that you would do if for example, you encounter a patient during a fit. Importantly, make sure that the airway is clear and that the patient is breathing. You would check the pulse. You would put the patient in the left lateral position, and you would possibly administer rectal diazepam, 10 milligrams if it's an adult, or 5 milligrams in a child. And you'd probably admit the patient as well, especially, for example, if it's the first fit, if the cause is not yet known, if the fit is prolonged, if there are poor social circumstances, if there's head injury, and if there are any residual problems, e.g. for example paralysis. So there are a few things there that you would want to consider, especially in the management of epilepsy as well. Now, sorts of things that you would want to counsel a patient on. This could be quite relevant as a pharmacist as well. First of all, safety. You would advise the patient ideally to avoid heights such as ladders and swim only under the supervision in shallow water. And those are obvious counselling points there. In terms of driving, unfortunately this is a bit of a concern in terms of especially patients with epilepsy. You can probably see here, patients with epilepsy are banned from driving on an ordinary licence for a year after their last fit. A licence can be granted if convulsions have been solely nocturnal, in other words at night, for at least 3 years. There's a total ban on vocational licences, in other words, things like lorry drivers, etc. And finally, after the first suspected fit, you would advise the patient not to drive until seen by a neurologist. Okay, so that's about driving. Okay, now in terms of first aid and seizure control, you would give advice to the relatives about first aid, especially during a seizure, and how to administer a rectal diazepam if necessary in the event of a fit. And you would also advise a patient to carry a medical alert bracelet just in case they're out and about and they have a fit as well. Okay, so we've covered 3 or 4 different things quite quickly. Let's go into drug interactions now. Now the major thing, there are a few interactions, but the major one is specifically with contraceptive pills. I mean, you can go and check with the BNF as to the other types of reactions that there are. But the main thing we're going to concentrate on is a contraceptive pill. Check whether the patient is taking any drugs which may interfere with anticonvulsants, especially with contraceptive pills. The effectiveness of both oral contraceptives and progesterone pills is reduced by these drugs: carbamazepine, phenytoin, phenobarbital, and primidone. So you'd want to use a high-level estrogen pill, or I should say, an alternative method of contraception. Now, sorts of side effects you would experience. These are, again, there are others as well, but the main drugs, carbamazepine, phenytoin, sodium valproate. You can see for yourself there's different types of side effects there are. Phenytoin, for example, very, very common ones: acne, hirsutism, and gum hyperplasia. With carbamazepine, you've got a few there as well. Sodium valproate, again, you've got some more there as well, which are quite common, especially if you take it. Okay, so we covered quite a bit of that already. Let's say, for example, you're a female and you want to potentially get pregnant in the future. Now, what the GP would do, they would advise female patients that they will need to be seen by the neurologist, especially if they're contemplating getting pregnant. There's a fine balancing act, obviously, between managing the epilepsy and the issues associated with taking anticonvulsants as well. In terms of breastfeeding, all anticonvulsants except for barbiturates can be prescribed for breastfeeding mothers. Now, in terms of prescription charges, this is quite an interesting one. All patients with epilepsy are exempt from prescription charges. Now, one thing that you would want to mention to the patient is to avoid triggers. There are several types of triggers, but these are the most common ones: alcohol, being extremely tired, and flashing lights. Again, it depends upon the individual. Not every patient will have these sorts of things, but it's just worth bearing in mind that these are sort of triggers that could potentially set off a fit. In terms of disease monitoring, if fits are still occurring after you prescribe the medicine, increase the dose of the first line anticonvulsant until the fits are controlled without unwanted side effects. Now, again, for the more clinically inclined here, you want to aim for specific therapeutic drug levels, ideally with carbamazepine between 20 to 50 micromoles per litre of blood, and the same sort of thing with phenytoin between 40 and 80. Alright. Now, if, for example, they're not controlled with the maximum dose of the first line drug, you would refer them back to their consultant. Okay, and after that, if their fits are controlled, what you would do is you would want to see the patient every 12 months, and then you would look at things like the side effects, the drug levels, and potentially counselling issues as well. Remember, I'm looking at it more specifically from the perspective of the GP here. Now, in terms of quality and outcomes framework for epilepsy, the sorts of things that the GP would want is, you would want an annual review of epilepsy medicines. You would want to record the date of the last fit, and also they would want to record the fit frequency as well. Potentially things that as pharmacists we can help them with as well. So that is it. I have done this at a very, very speedy level, so thanks again for listening to this. Again, if you do want this presentation, if you want the web mind map as well, please contact us at the office and we will send it on to you as well. Thank you very much again.